Hello, why don't we get started? This next session is going to be a tag team event, all right? And they're going to talk to us about adding insulin. We've talked about adding other things. How do we add incorporating along adding insulin? And we have Dr. Trence and Lucia Novak. Dr. Trence is an endocrinologist, and Lucia Novak is a nurse practitioner and does a lot of diabetes teaching. Welcome.
Thank you all, and thanks for inviting us to speak about a topic that both of us are quite passionate about. So we're going to spend some time looking at incorporating long-acting insulin therapy into the physiologic approach of diabetes management. Here are our credentials, our disclosures, our learning objectives to recognize the negative clinical and socioeconomic impact of clinical inertia, the delay in actually starting insulin. We'll look at some strategies that we can implement to overcome patient as well as our own personal barriers to the early initiation of insulin therapy. We'll assess the latest clinical data surrounding the efficacy, safety, and pharmacodynamic profiles of long-acting insulins, and we'll look at developing some individualized treatment plans to foster patient engagement. So let's jump in to our presentation. As I mentioned, this is an insulin-focused presentation, and we just want to remind everyone of the progressive nature of type 2 diabetes and the need for insulin, which will come for everyone given a long enough period of time with their diabetes diagnosis. And we have examples of 3 studies, one I think of which is very familiar to most of us, the UK-PDS, where you can see that 75% of individuals with newly diagnosed diabetes needed insulin within 9 years. The Origin study, you can see just over 10% of individuals, whether they had impaired fasting glucose, impaired glucose tolerance, or frank diabetes type 2, required insulin within 7 years. And the Today study, looking at adolescents, again, you see a huge proportion of individuals requiring insulin, and that in a very short period of time within 1 year. The problem is that we tend to kind of delay, quite frankly, the initiation of insulin, even when A1Cs are quite robust, over 8%, and despite the fact that many of these individuals already are on 2 or even 3 oral agents. Does it make a difference? Well, yes, it does. And there are a number of studies that reinforce the need to actually consider insulin quite early and the potential benefit of starting insulin early. This is actually a study from a Chinese population looking at individuals with just newly diagnosed type 2 diabetes, drug naive, so they had had nothing pharmacologic actually to treat the diabetes with, and they were randomized into 3 groups. You can see that in the purple on the bottom were the oral agent group, what we tend to do, I think most of us, currently in the US even. And then you see in the top 2 lines, the blue and the orange, these are people who were started on insulin. Believe it or not, and that orange were actually pump users. So right off the bat, they were placed on a pump, and the ones in the blue were placed on basal bolus insulin, the goal being to normalize blood sugars, and then once the blood sugars were normalized after 2 weeks, to actually stop all of the agents. So they stopped their insulin, they stopped their orals, and these people were followed over time to see what happened, with the goal really of seeing what their blood sugars were. And the goal being that these blood sugars were normal. And you can see that over the course of time, that the ones that did the worst were the ones on oral agents, not the ones on insulin. They actually did better. That was beta cell preservation. When to consider insulin in patients with type 2 diabetes? Well, obviously this can be certainly a choice after metformin has been started, or when the combination oral approach or injectable agent just doesn't work. High fasting or high postprandial levels actually are better approached with insulin. Unacceptable side effects of other agents, patients who advance hepatic or renal disease, where the processing oral agents is quite different. Circumstances such as use of high-dose corticosteroids, infections, pregnancy certainly, patients who are hypoglycemic in the hospital, and those who have really uncontrolled diabetes. The benefits of insulin are that it works. It clearly is the most effective medication that we have for controlling blood sugars, whether they're fasting or they're postprandial. And as I mentioned, there is that potential to preserve beta cell function and insulin release over time. I mentioned the Origin study. There are certainly other studies that actually also certainly show us that that early initiation, despite the fact that we don't do it normally, can be very efficacious. And the concerns that came out a few years ago about insulin being associated with the potential for increased risk of developing cancer or heart disease, I think, have now been debunked.
Okay, so what's the issue with starting insulin in our patients? The earlier panel today with Dr. Jane Dickinson, especially with all of her work in the language surrounding how we speak to our patients with diabetes and about the diabetes as a disease process itself, is one of the ways for us to start thinking about how to start breaking down some of these barriers. Our patients come with their own concerns. Fear of needle is one of them. Usually it's not the needle itself, it's what that needle is attached to, and that's the insulin. How many have said, I ain't claiming insulin? I ain't ready for that, okay? Mainly because that insulin usually means that they have failed. And we know that it's not that they have failed, but their body has continued to progress with the disease, and the initiation is therefore needed in our patients. They're going to come with it at some point in their career. It's inconvenient, it causes blindness, I'm going to lose my foot, those kind of things, mainly because of what their own experiences have been with other family members. The clinicians also have their own concerns. It's a lot of time involved in starting patients on insulin. Just broaching the subject actually gives a lot of providers heebie-jeebies, because you know that now you have to talk about hypoglycemia, you have to talk about weight gain. Monitoring blood sugars becomes an important part of managing patients when they're put on insulin. So time and having adequate resources becomes a concern for many of the primary care providers. And even in the endocrinology setting, we worry about where do we find these resources. But together, both of them all have shared concerns, and the main one being hypoglycemia. The next one, probably weight gain. A lot of our patients struggle with weight throughout their lifespan, and so adding insulin usually increases that problem for them. The complexity, and of course, we cannot get away from the issues surrounding cost. However, the Diabetes Attitude, Wishes, and Needs study actually explored the problem with initiating insulin a little bit more deeply, looking at the emotional and psychological issues surrounding it. And what we find on the patient side of the equation is that 48%, almost half, believe that they are blamed when it's time to start insulin, that it's somehow their fault. 57% are worrying about starting it probably as soon as they heard the word diabetes enter into their problem list of what they're actually needing to manage now. But what's really important is almost a third of them would be unwilling to even use it, even if you prescribe it. Clinician complacency is the other half of the equation, okay? Unfortunately, the United States has the notorious distinction of being among the top 3 countries to delay starting insulin appropriately, okay? Half of us believe that there is no good benefit to adding insulin to the medical care. And they believe, we put our own concerns. We believe, 65% of us believe that the patients are more concerned about starting insulin. We're not having that conversation that we need to have. Most people with diabetes are not actively engaged by their healthcare professionals to take control of their condition. Education and psychosocial care, unfortunately, are often unavailable. So what is the cost of delay? We have a lot of data that actually supports that every 1% reduction in A1C or glycemic control really reduces, to an exponential effect, microvascular complications. We don't really have any data that supports reducing A1C or getting glycemic control improved really impacts macrovascular complications. But what we do know, and what this study from Paul and colleagues has shown, that delaying the initiation of insulin or delaying intensifying treatment in our patients with diabetes makes underlying macrovascular disease worse. Composite cardiovascular events by 62% in doing nothing for just 1 year. These are the things we need to think about, what that delay causes. So we have some guidelines available that are supposed to help the primary care provider manage our patients with diabetes, because before 1995, when metformin was brought to market here in the United States, we had a very limited choice: sulfonylurea or some insulin. And the insulin was NPH, regular, and maybe U500 at the time. There was some ultralentane animal insulin as well. Now we have 12 different classes of agents for you to choose from. So that's why I have job security standing before you today. Okay? And how do you know what to choose? Well, when you look at the ADA guidelines and ACE guidelines, they list the medications in an order of most effectiveness as far as helping reduce the blood sugar and improving the A1C, but also trying to choose agents that come with less risk for hypoglycemia and weight gain. And of course, balancing all of that with side effect profile and cost for the patient. ADA has theirs listed not as clearly as most providers would like. They actually list their agents in order of how they came to market. So at first glance, if you're not familiar with what you're looking at, it almost looks like sulfonylureas would be your first choice after metformin. But that's not how the ADA actually recommends. ACE does a little bit better. Okay? They actually do list their agents in a hierarchy, again, looking at what comes after therapeutic lifestyle and metformin, and then how do you progress with treatment from there. And they list their agents in order of less likelihood to cause hypoglycemia as far as efficacy, the GLP-1s being the first choice after metformin, and those are non-oral agents. Those are all injectable, but those are the first choice because they are also the most effective when you look at the ominous octet and their ability to impact 6 of the pathological reasons why patients experience hyperglycemia. The important thing to understand is you're choosing medications that are acting and behaving synergistically, okay? And we don't typically stop agents when we advance therapies unless there's no synergistic benefit, cost, side effect, and those kind of profiles.
So we've talked about the choices that have been made, that you can make, and you can see there are many. But let's bring this back to the insulin issue. As you can see, the evolution of insulin products, actually we'll be celebrating 100 years of insulin here very shortly from 1922, to then actually looking at the different kinds of insulins that are coming down the pike, have come down the pike. And I might add that there's actually another one, actually just off that 2015 slot, for the faster-acting Fias, faster-acting Novolog, faster-acting Aspart. So we are rapidly beginning to see more and more insulins in our armamentarium, in our toolbox. The currently available insulins you can see listed. There are many to choose from, so if you thought that you had many oral medications to choose from, injectables, you certainly also now have many insulins to choose from. The rapid-acting analogs I think we're familiar with, the Lispro, the Aspart, and the glulisine, the inhaled human insulin, and as I mentioned, the faster-acting insulin Aspart. Shorter-acting insulins, the regular insulin, and perhaps that U500 should really be a part of the NPH armamentarium because it acts more like NPH than it does a short-acting insulin. We also have our familiar basal insulins, as you can see, Glargine and Detemir. And we have now these ultra-long-acting basal insulins, which come in different concentrations, Glargine U100 and Degludec U100 and U200. That's Glargine U300. Notice, if you look, that the onset of action is that these tend to develop very slowly over 6 hours. They're nearly peakless, both of them. But notice the duration of action, which is very, very, very different. Look at Glargine U300. That's almost a day and a half, 36 hours. Degludec, both of them, whether it's U100 or U200, 42 hours, almost 2 days. If you look at what that actually means in terms of the steady state that's achieved, well, we're being stroked out here. Yeah, there you go. What this slide is trying to show is that there is a difference in terms of the actual action of these basal insulins compared to insulins that we are familiar with. So we've been told that Glargine is a very flat insulin, and as we've learned, it's not as flat as we would like to think. And this is a way of taking a look at it in terms of what's... in terms of a glycemic clamp, where you're trying to keep the blood sugar as steady as possible with a dose of insulin that's been given, and then you measure what kind of amount of of glucose you actually have to use to maintain that steady state. And you'll see, once we're able to see it, that for NPH and for Glargine and for Detemir, there's a lot of this kind of thing. It's kind of up and down. In contrast, if you then start to look at what U300 Glargine, it's very flat, very, very flat. There is no need to continue to add glucose to make that glucose actually as stable as possible after a dose of insulin has been given. And the same thing, we're back. Back in business. All right, let me just advance. So you can see, as I mentioned again, that very flat effect from U300. And if we look at Degludec, again, irrespective of the dose that's given, that's about as flat a line as you will ever get with a long-acting basal insulin, background insulin, basal insulin.
So your patients actually feel better when they're on those flatter acting insulin without all of that glucose variability. So when I'm talking to my patients, I'm always bringing up insulin at the very beginning of our conversation, mainly because there's such a stigma associated with it. Don't they come into your office and say, what's my AC1? And I know it ain't good because I've been bad. And it's like, okay, we got the right letters and numbers, maybe not the right order, but we're good here. So again, making sure they understand that this is a disease, just like any other chronic disease, that regardless of what Dr. Oz says, if you put it in a blender, it's not going to cure it. Okay? It's progressive, and we're going to need to advance. And I tell them that insulin is always a safe and an appropriate agent depending on what's going on. So making sure they understand that it's not really what I use or recommend that you use to treat the diabetes. It's why we're doing it. We're doing it to reduce the risk of those complications that they're afraid of. We're doing it to also help them feel better in the short term because they don't feel well when their blood sugars are not well managed, whether there's a lot of glucose variability or just that they're having hyperglycemia with their agents or, of course, hypo. So, again, that shared decision making that was brought about at the previous talks with the other panelists, how important that is to bring them into the equation. I tell my patients, you are an expert in you. You know your life. You know your body, you know your history, you know what you like, what you don't like, what your goals are. But I'm an expert in the area of diabetes. I know this disease inside out. I know what it's going to cost you. I know what harm will come if we don't manage it well. And I know the drugs really well. Somewhere, the two of us need to come up with the plan that works for you. And I tell them that they always have veto power because it is their disease and it is their life. So having that part of that conversation from the very beginning. Asking the right questions. Again, this takes time. This isn't something you can do in 15 minutes. So this is something that you're probably going to do at every appointment with your patients, even when they're not necessarily going to be placed on insulin or you don't think they're ready for it based on their clinical profile that you have before you. It's always good to start asking these kind of questions to them to find out where they are so that you can properly direct or get the proper people involved in their care, because it does take a team. You cannot do it yourself. So tricks of the trade when you do actually have to start any injectable insulin, injectable medication. This is not limited to just insulin, okay? Making sure they understand how to do it. If you can have them actually do either an actual injection in the office or at least a dry needle insertion in the office, it takes away a lot of that fear that they have when they go home. It gives them that feeling that they are empowered and will be able to do it. A lot of patients associate the pain of finger sticks with what they expect to feel when they inject insulin, and they are very much surprised when it is different. I will tell you, in the world of diabetes for sure, size does matter. You should never be using a needle length greater than 6 millimeters in length for any patient, regardless of how voluptuous they may be. We do know that they can inject insulin in the muscle with an 8 millimeter length needle. So please do not prescribe those for your patients. I'm making sure that they also use a new needle. So what are the sweet spots? Making sure they rotate their sites. I can't tell you the last time I saw a patient who had diabetes for 35 years and the blood sugars were all over the place. I couldn't make sense of them, and I said, show and tell always works. Show me how you're injecting your insulin. And he lifted up his shirt and there was an egg next to his belly button. For 35 years he was injecting, he was rotating his site in the same 1-inch parameter. I couldn't believe it. So making sure that they understand that they've got a lot of real estate to choose from and not to just keep using the same areas. Hypoglycemia is always a concern when we're dealing with insulin, always, always, always. The newer ultra-long-acting insulin have been shown to cause less problems with severe hypoglycemia, less problems with nocturnal hypoglycemia, but I didn't say they cause no problems. So anytime you use insulin, there is always an inherent risk. So the conversation of how to detect it and how to appropriately treat it comes into play. Rule of 15 is usually what I tell my patients. They're not reporting it, probably because we're not asking the right question. Are you having hypoglycemia? Hypoglycemia. I don't know what that is. So I'm obviously not having hypoglycemia. Or better yet, are you having low blood sugars? Well, you tell me what low is. I feel all of a sudden we're in a chess match. Okay? Well, how low is low? Is low, what's low for you? So again, making sure we have numbers to quantify what we're talking about and treating it precisely. And that's a tool for you to use. I recommend you share this with your patients. Who has time for all that? Again, it takes a village. It takes all of your supporting staff, your MAs, your LPNs, your RNs, your CDEs that has been mentioned over and over again. There's only 2,000 board-certified advanced diabetes management nurse practitioners in the country. I am one. I call that job security. But if you can find us, use us in your practices to help manage those more complicated patients. Diabetes education, I cannot stress enough. 81% of patients who received it found it helpful. Unfortunately, only about half of them are even being recommended or referred for it.
So how do you start insulin? And again, we really want to keep it simple. It's simple for the patient, it's simple for the patient's support system, and it's really simple for you actually to start something that's really a step 1, step 2, step 3. And as you can see, this is an algorithm that is widely used. You start the once daily long-acting insulin, and many times we just do a conventional 10 units at night. We know that for most people that's just not going to be enough, but heaven forbid that with that first injection anyone has a hypoglycemic event. And then you spend years trying to convince that person to start insulin again. Some people will use a 0.1 to 0.2 kilogram unit per kilogram approach. You certainly want to engage the patient and have them checking their blood sugar, whether it's by finger stick or with some of our newer modalities with the continuous glucose sensors, but you need to have some direction. And this is where you can empower the patient, empower that person to say, based on the data you're getting, it's not just data for the sake of data, it's not just numbers, but you're really going to use those numbers to really suggest whether you need to advance that insulin dosage. And as you can see again, a protocol for a target of 80 to 130 fasting, increase the dose by 0.4 units per kilogram up to that over every 4 to 7 days. If they have a hypoglycemic event, they're under 70, you back off, reducing the insulin by 10 to 20%. And you can continue this regimen with, however, a caveat that I would add, and that is not to allow the patient to get from 10 units to 100 units before you see them again. We really need to put a cap. That happens more frequently than one would like to have happen. Long-acting basal insulin, let's talk about Glargine U300, one of our new basal, ultra-long basal insulins. In insulin-naive patients, obviously in type 1 individuals, you want to start with 1/2 to maybe 1/3 of the daily insulin dosage calculated using a 0.2 to 0.4 unit per kilogram per day. So these are individuals who have to start an insulin rather promptly. I would certainly give a reminder of the daily insulin dosage. It will need to be partly short-acting. You can't have a type 1 individual do very well on just long-acting. So you want to divide that other 1/2 of the total insulin dose among the meals that they have. Some people have 3 meals, some people have 2 meals. So again, that percentage of pre-meal insulin will depend on the amount of meal ingested. With type 2 individuals, start with that 0.2 units per kilogram per day. And again, no one would fault you if you wanted to start lower, 10 units as we mentioned, or even a 0.1, just to prevent any problems with hypoglycemia. With the type 1 or type 2, when you already have them taking insulin and you want to change to a basal insulin, that is the ultra-long basal insulin, you can actually use the same initial dose as the once daily insulin. The difference is that when you have someone on twice a day NPH, so this is a difference, that you really want to calculate 80% of that dose when you start the ultra-long basal insulin. And the reason for that is that NPH actually acts as both a basal background insulin and a prandial pre-meal insulin. So as you're switching over, you're really focusing on the basal effect. Therefore, that back off an 80% total is usually recommended. Is it effective? I mean, it's great to talk about changing insulins, but does it really work? Does it do anything? And I think you can see that certainly with regard to hypoglycemia, which is the graphic that you see on the left, as well as nocturnal hypoglycemia, the graphic in the middle, that clearly there is improvement. There's less hypoglycemia. That's one big, huge plus of these new ultra-long basal insulins, that hypoglycemia is much, much, much less. I think, again, if you can look at A1C, you can look at insulin dose and weight, in particular A1C, maybe not a huge improvement. We don't see that these insulins really help A1C, but it helps to maintain an A1C and maybe sometimes improve it without the hypoglycemia. That's the big take-home message. And I think also if you look at weight, there is an advantage there too. Just because they are very flat insulins, you don't need to be treating hypoglycemia with extra calories. If we look at Degludec, it comes in two concentrations, a U100 and a U200. In insulin-naive patients, type 1, again, you have to start insulin. There's no way you can get around it, and the same type of thing applies as we just spoke with the U300 Glargine, that you'll calculate a dose of 0.2 to 0.4 total per day, and then divide that up so that half of it is in the basal and half of it will be in the mealtime insulin. In type 2 individuals, again, you'll start with a 0.2. You can start with, again, 10 units. There's nothing wrong with that. In those who already are on insulin, and most of the time I think we're going to be converting individuals rather than starting de novo, just given some of our insurance recommendations for step therapy, you again want to do a one-to-one conversion. I will say, however, that for the Degludec, sometimes this seems to work a bit more efficaciously, and you want to back off a little bit. Although certainly the recommendations traditionally are one-to-one, it's not a bad idea to consider even a 20% or 30% decrease. We see this very, very, very frequently, and again, I think it's because we really are using a basal and not a combo basal and prandial effect from our other long-acting insulins. And again, you can see in changing from twice a day NPH, the initial dose, you just want to be sure that you're not causing any problems, and an 80% total dose total. So decreasing 20% is not a bad approach. Again, safety trumps everything when you're first starting the insulin. And again, we can look at safety profile. Again, less nocturnal hypoglycemia, less overall hypoglycemia, certainly less severe hypoglycemia. Again, we don't see much of a change in A1C. So the point is here that you're exchanging one insulin for another because of less hypoglycemia, potentially less weight gain, and clearly a person who's much happier because they're not struggling with hypoglycemia, or their family members, their colleagues, their work associates. Another interesting thing with particularly insulin Degludec is that it has this very unusual, and it's kind of hard to wrap one's head around, the feature that you can actually, once it's been on board, so it's been given at the same time for at least a minimum of 3 to 5 days, and oftentimes we'll just make it easy and tell the patient for 1 week, that if you forget that dose, you can give it the next day. In fact, what this study shows is that you can actually go anywhere from 8 to 40 hours apart, and it will actually be a steady state. I mean, it's hard. We don't think of insulin like that. How can you vary it almost 2 days and not have any kind of problem with hypoglycemia? But we have data that certainly support that that variability exists, and it's very safe. So think of that. Oh my gosh, I forgot my insulin. I fell asleep last night. Give it the next morning, no problem, and you can give you another dose, the next day's dose in the evening as you normally would. Terrific for the teenager, terrific for the college age, terrific for all ages. Let's face it. Let's face it, for all people who are using insulin, we forget. So we now have a case study, and we'll talk about Raymond. So Raymond's a 59-year-old man who was diagnosed with type 2 diabetes 6 years ago, quite recent, has a history of pancreatitis, also has some hypertension, which has actually been stable, managed well on his medication regimen. With regard to his diabetes management, initially, his primary care physician followed the guidelines, lifestyle first, added metformin, and the A1C was at 7, went up to 7.2, but then unfortunately went up to 7.8 after 3 years. At that time, a sulfonylurea was added, and the A1C unfortunately didn't improve a whole lot, but unfortunately there was weight gain with this, and there was a lot of hypoglycemia, which caused the patient to say, I don't think I like this drug, I'm going to cut back a bit. And well, maybe if I just skip it, I'll be even better and not have the hypoglycemia at all. An SGLT2 inhibitor was added when the sulfonylurea was decreased, as he talked about this with his clinician, and weight loss occurred. Very happy about that. No hypoglycemia, happy about that. But now look at what has been created. So here we have someone on metformin, on an SGLT2 inhibitor, but the A1C is now 8.5%. You can see the fastings. And clearly, you and Raymond are concerned about whatever else you might add, because that hypoglycemia was severe. We don't want that to happen again. So, what would you do? Any thoughts from the audience? I hear murmurings. Yeah, right. It's time for insulin. It's the time for the insulin talk.
Especially with his history of pancreatitis, it limits the whole incretin group of medications. That would both be the DPP-4 inhibitors as well as the GLP-1 receptor agonists. So when you're seeing fasting elevations, even when he was on a sulfonylurea, he was experiencing, yes, hypoglycemia, but sulfonylureas are truly basal type of insulin secretagogues. And so when a patient is not doing well on a sulfonylurea, that's the time to probably consider switching to a basal insulin and stopping the sulfonylurea. We actually increase, rather remarkably, the risk for severe hypoglycemia in our patients with type 2 diabetes when you combine sulfonylurea with insulin. And remember what I said earlier, you want to choose agents that have synergistic benefit when you're combining them. There is no synergistic benefit with using a sulfonylurea and basal insulin, so that's when you would start considering pulling that type of medication off. But so, what type would you use?
So we agree to disagree. So we'll say that, and sometimes that sulfonylurea can still be used. Obviously, when someone has an A1C of 8.5%, you're dealing with both a fasting hyperglycemia and a postprandial hyperglycemia. So when you get to an A1C that's more in the 7s, you're more likely to deal with a postprandial hyperglycemia. So it's something to kind of keep in mind in terms of mechanisms of drug action and where best you can actually create the milieu of drugs that the patient actually needs. So sulfonylureas are not indeed contraindicated totally, but you must use them with caution, because I certainly would agree that the risk for hypoglycemia is not minimal. Sometimes what we will do is we will switch actually to a meglutide. Those are very short-acting sulfonylurea-like drugs. I'm cautious because they're not sulfonylureas, but they're short-acting, and they're really designed just to be taken with a meal. They can be a bit safer. They're not without their risk for hypoglycemia also, but that potentially can also give you a prandial effect without the hypoglycemia risk.
The problem with those is that now you're increasing frequency of medication doses. Those have to be taken before the meal. And I don't know about you, but I see a certain variant type of diabetes quite frequently in my office. They're the domestic type of diabetes or the breakfast variant, because they don't have diabetes or they don't want to perform diabetes-related tasks when they're not at home. And we know that when we increase the frequency of medication administration, we tend to increase the chance that those medications are going to be missed. So again, this is where you really need to have that conversation with your patient. Find out where they are, what they're willing to do, what fits into their lifestyle. But when we go back to Raymond in particular here, you are absolutely correct in your belief and your knowledge and your recommendation that basal insulin is the way to go for him at this point. Would you stop the metformin or the SGLT2 inhibitor? that he's on?
Well, you wouldn't want to do that. Metformin with insulin will decrease the need for total insulin dose by as much as 25%. Data that we have is from 12 to 25%, so it will minimize the insulin dose, and quite frankly, metformin's a lot cheaper than insulin. Yeah. So anything you can do to keep that insulin dose down, your patient will be very grateful for. So I think that's certainly something to continue.
Very good. So we'll go to the second case, and our second case is Melinda. She's a 59-year-old woman who was diagnosed with type 2 diabetes about 10 years ago with a buy one, get three free disease that we typically see with diabetes, the hypertension and the dyslipidemia, which fortunately for her are both stable and at the appropriate goal. Her current medications for her diabetes include the metformin, the SGLT2 inhibitor. She's also on a weekly GLP-1 receptor agonist because she's got a PCP that rocks and rolls. And she's also on 70 units of your traditional U100 type of Glargine insulin at bedtime, so your Lantus or your Basal type insulin at bedtime. Her current A1C, however, is 8.2, but she's experiencing nocturnal hypoglycemia at least twice weekly, which is twice weekly too many, because despite having elevated blood sugars before she goes to bed at night. And for the past 3 weeks, she has been having snacks to prevent the lows and has gained weight, is very unhappy. My patients tell me they don't want to wake up to statins, so they will do whatever it takes to wake up the next morning, even if that means self-sabotaging their medication regimen because they're afraid of those lows. They don't want to go low at night. So what are we going to do with Melinda here?
I think, first of all, we should take a look at this person who has a much longer history of diabetes. Our first patient, Raymond, has 6 years. This person has 10 years of known diabetes. Well, you know that it takes anywhere from 6 to 8 years, unfortunately, to diagnose diabetes. So technically, she's had her diabetes at least 15 years, maybe even closer to 20. So the first discussion point in your mind that you'd have with the patients, what are the goals? What goals of glycemic control should there be? Is this a person that I want an A1C at 6.5? Or is this a person that maybe an A1C between 7 and 8 would be adequate? So again, we don't have much history here in terms of any history of cardiovascular disease, renal disease, other comorbidities. We'll assume that there aren't any. So that would mean that you actually could be a little tighter in your target with this person. Not necessarily between 7 to 8%, but because, again, no comorbidities, a healthy person, otherwise, you want to push a little bit harder. Now, hypoglycemia is the big barrier to everyone treating someone with diabetes. That will make a huge difference in terms of what you recommend, but even more so in what the patient actually follows through with. So in this person, if you look at this, she's taking a huge amount of Glargine at bedtime. So your first reaction would be obviously to, I hear murmurings, louder. Yeah, cut back. Certainly cut back on the Glargine. Glargine, as I showed, isn't necessarily a flat insulin. It actually has a bit of a peak for many individuals, and that's variable. So you certainly would want to have a lower dose. What would be the advantage to changing her to an ultra-long insulin? I mean, obviously her formulary will cover U100. It should cover U300. Remember, we looked at the fact and the data that showed there was less hypoglycemia with a U300. So this would be a person that you'd not only cut the dose, but also would consider a U300 switch.
I think it's important to just pay attention also to what she was seeing in her blood sugars. And this is a classic example of where the A1C does not tell you the full picture. So an A1C of 8.2, if you didn't know she was having hypoglycemia, if she didn't share that with you, maybe your natural inclination would have been that she needed even more of the insulin. So the A1C does not tell you the full picture in this. It doesn't tell you that she's having those lows. Her A1C might actually be elevated because she is having the lows and she's eating through them. She's incorporated defensive eating in her daily habits. The fact that she's having elevated blood sugars before nighttime also tells you about what we see typically with the pharmacokinetics and pharmacodynamics of these U100 Glargine type insulin, is that they're not lasting a full 24 hours. They tend to last about 19 with a wear-off effect. So her highest blood sugars are in the evening before bed and her lowest are at night. Again, exemplifying another reason why those ultra-long-acting basals might actually be a more appropriate choice for her. I don't know if I would necessarily change much else with her, even though she might be having some problems with post-meal elevations as well, just putting her on a stable basal.
So I think if we look at what we've been trying to actually present in the short time that we have left, we have some take-home messages. We have some guidelines, as were mentioned, to be able to use insulin. We certainly have the option of basal insulin followed by bolus, as we started to talk with our last patient. And we certainly have these long-acting basal insulins that decrease hypoglycemia. While they may not improve A1C, they certainly can make the patient's life a lot more flexible when you talk about Degludec being used anywhere from 8 to 40 hours apart.
Thank you so very much for your time.
Thank you for your presentation.